and also which clinical condition which you would you suggest to use what kind of sealers, right? So first and foremost, what exactly are sealers? Sealers are binding agents which are used to fill the gaps between the root canal and the obturating material. And it also helps us in filling all the irregularities in discrepancies, lateral canals, as well as the accessory canals, right? Now, you need to understand that when you are placing your master cone inside the root canal, still there will be a space between your radicular dentine as well as your gutta percha cone. So, in order to fill these and act as a monoblock technique, we need sealers. So, they also, in addition to that, they help us to fill out any kind of irregularities, any lateral canals as well as the accessory canals. So these are a few first 2 to 3 slides would be a little theoretical where we need to go back to our basics to understand that what are the ideal requirements of sealers. They provide a very excellent sealing ability. So apically as well as laterally. It helps to produce adequate adhesion. Of course, we need a radio opacity. We need something which is non-staining, not causing any kind of stain to our root canals or to the tooth, as well as dimensionally, it should be stable. Also, it should be very easy to be introduced inside the root canals. It should be insoluble in tissue fluids. It should be have a slow setting, of course, antibacterial, and should be absorbable when extruded periapically. Right. So, what are the different functions? So, we have antimicrobial agent, we have the binding agents. It should act as fillers, is basically filling gaps between the cones and the walls. Then it should act as lubricating agent when you're using your obturating material, and of course the radio opacity. Moving on to very brief introduction to classification. Now we must have read a lot of classification which is mentioned in books. But what about zinc oxide sealers? So most of the people who might be students or undergrads or postgrads who might be listening to this webinar. So when you come to zinc oxide sealers, that's how we started our root canal journey. That's how we started doing our obturating techniques by using zinc oxide sealers. So zinc oxide sealers have been used from innumerable time, and it had a lot of advantages. That is why it is still, I think, being used in the market. But also it came up with a lot of disadvantages. So the most important disadvantage, if you ask me, was the setting time. It was almost 48 hours of setting time. And the most important, another important factor was it was very highly soluble over the period of time. So because it was very highly soluble over the period of times, it could lead to discrepancy between your obturating material and the radicular space. It could also engrave lot of periapical infection. And of course, eugenol has an irritant property, and it inhibits the resin polymerization. And also, few studies have demonstrated that it had cytotoxicity. So, given all the disadvantages, still the advantages, if we look forward to, was it is long-term record of success. Of course, like I told you, it is cost effective. One bottle of eugenol can be used for a lot of cases. And the best part is it can be easily retrieved in cases of retreatment. Moving to next would be the calcium hydroxide base sealer. So of course, it came with lot amount of antibacterial properties, providing a better healing, a better periapical healing, also stimulating some kind of tissue formation and extended biocompatibility. Moving to epoxy resin-based sealers, so these were having very low solubility. The working time was enhanced, so you could easily, place your all kinds of master cones as well as your accessory and lateral cones. And in this criteria, we had the AH plus sealers. So AH plus sealers is considered to be the benchmark for clinical comparison as well as the benchmark for carrying out most of our cases. So I am sure that most of us would had gone hands-on of working with AH plus sealers. So plus sealers have a setting time of 8 to 24 hours, but it also depends upon humidity. So, there could be some kind of differences when it comes to weather changes, extreme weather changes, and it gets accelerated by moisture. Whereas when we come to a few disadvantages of using epoxy resin-based sealers, so they were, initial cytotoxicity during setting, difficulty during retreatment cases, potential allergic reactions. There were very few cases reported, but yes. And of course, few cases of also tooth discoloration. Coming to the latest advantage of bioceramic, that is calcium silicate based sealers, having tricalcium silicate, dicalcium silicate, and of course, calcium phosphate. And they have various agents for their thickening agents. So we also have water based and we have pre-mixed bioceramic sealers, and they had very excellent biocompatibility and bioactivity where even some kind of sealer, if it has extruded beyond the periapical space or periapical foramen, it still acted as one of the best sealers which could be used as for biocompatibility. Lowest micro leakage, lot of evidence based articles regarding bioceramic sealers having lowest microbial leakage promotes a lot amount of hard tissue formation, and of course having antibacterial properties. But definitely the most important disadvantage with bioceramic sealers is it is very difficult to remove during our retreatment cases, and also it has very high chances of setting very fast. And of course the bioceramic sealers almost has a very good amount of uh, when it comes to cost factors. Coming to what exactly was the mechanism of bioceramic sealers and why did we come up with this is because it has four phases. We need to understand the mechanism of bioceramic sealers. So the first was the hydration reaction, where the calcium silicates are going to react with the moisture that is present in the dentinal tubules as well as in the periapical tissue, and it is going to form an hydrate gel or a calcium hydroxide. When it has already bonded and formed an hydrate gel, it is now going to release the ions, that is the calcium and the hydroxyl ions. So there the pH is going to be very, very high. So that is, more alkaline nature, that is 12.8, again stimulating more kind of mineralization. The third is the hydroxide formation. So once the calcium ions has been released, it will form from the phosphates of the dentine. It is going to precipitate the hydroxyapatite crystals and thus having a better sealer and dentine interface. Now, this is going to act as a chemical bonding to the tooth structure. That is exactly that we want. We don't only want a mechanical bonding, but we also want a chemical bonding when it comes to bioceramic sealers and helping in forming a monoblock technique. So we have the sealer, we have the gutta percha, and we have the radicular dentine. That is, it is going to diffuse with the dentinal tubules which are present in the radicular dentine, form the hydroxyapatite crystals with the release of calcium and the phosphate ions. And of course, further moving to the fourth step is the bioactivity, where it helps in promoting osteogenic and cementogenic activity, helps in stimulating periapical tissue regeneration, and finally forming the infiltration zone, that is MIZ, mineral infiltration zone. Now, in this case, the clinical application that I would like to suggest here is do not over dry your canal. So many times we might be wondering that you have taken your gutta percha, the master cone is proper, but when you are going to place your sealer, you sometimes see that your master cone is short. Okay. The reason being ki never dry your canals. Whenever you're checking your master cone, make sure that it has some kind of coating of very thin layer of sealer. Okay. When you're checking the first master cone, or rather, what you can do is always have some kind of moisture present in the canal. So let some kind of saline be present inside the canal. Don't over dry your canal. So moisture is very important when it comes to setting off the bioceramic sealers. It is required for hydration reaction. We need the moisture to be present. So even you have to leave the final irrigation. When you do it, you have to leave the canal with slight amount of moisture content present so that the bioceramic sealers can easily diffuse the calcium and the hydroxide ions and cause a better bonding. That is very, very significant for us to understand, right? Okay. Next is you have to avoid immediate post placement. This is also very important. Do not rush through placement of posts immediately, okay? Because it is a slow setting process. It takes 4 to 10 hours before we actually proceed with post and core um, materials. Okay, so coming to glass ionomer and silicon-based bioceramics silicon-based sealers. So we have glass ionomer sealers as well as silicon-based sealers. Whereas the glass ionomer, of course, will have the same fluoroaluminosilicate glass material having an acid-base reactions like we already know. In this criteria, we have active GP and Endion as two of the products. Whereas when you come to silicon-based sealers, we have the polydimethylsiloxane katabacha powder, and it also helps in providing slight amount of expansion and helps in improving the seal. So the products here are Gataflow 2, and Rico Seal. So when you look at an overview, so anybody who wants to, can take a screenshot of this. So if you look at an overview of the sealer type, the setting reaction, and the setting time, this is exactly what where we stand. So when we look at the bioceramic sealers, they have a setting time of 4 to 10 hours. But when we look at to GIC sealers, we have 10 minutes max. And then we have silicon-based sealers, which are 15 to 30 minutes. Now, moving to the heart of my presentation and the lecture today, that is the clinical considerations for root canal evidence-based clinical guide. Now, first and foremost is why do we need the root canal sealers? So here is a very simple example is that we want a hermetic seal. So what basically is a hermetic seal is when it is going to prevent any kind of bacterial infection or any kind of reinfection happening in the canal. And it also helps in periapical healing, providing um, a monoblock technique. So the sealers are very essential because it helps in entobing any kind of bacteria which might be present within the dentinal tubules. It also helps in filling any kind of irregularities which will be present in the root canals. It also helps in filling up gaps between the gutta percha as well as the canal walls. It helps in sealing the accessory and the lateral canals, also acting as a lubricating agent during obturation, and it helps in bonding the core material to that of the canal walls. So these are very important and significant features that we need to understand, that why do we need sealers and why is this topic very important that we are discussing. When we know that our master cone has exactly fitted inside our root canal system, then why are we focusing on sealers? Okay, but trust me, the flow of the sealers will depend upon irrigation. If you have done a proper irrigation, if you have irrigated and removed all kinds of necrotic tissue and the pulpal tissue from your accessory canals, from an isthmus, from two canals which are joined by fins and extra canals, if you have done a proper irrigation, the sealer is only going to flow in that area if you have done a proper irrigation along with that of an activator. Now, in case of vital pulp and necrotic pulp, when it comes to vital pulp, the clinical consideration here is that we have to have an aseptic environment, and your priority has to be the sealing ability. So the recommended sealers for pulpitis cases will be AH plus sealers. We have zinc oxide sealers, and of course, the best seal is provided by bioceramic sealers. Okay. Coming to necrotic conditions. In necrotic conditions, the antibacterial and bioactive effects has to be given more significance as compared to that of sealing ability, because the bacterial load is very high. So in cases of, especially when there are very large periapical radiolucency, you need to use sealers which are having the best choice of antibacterial properties. So here also recommended could be bioceramic sealers. Likewise, I told that it has one of the best antibacterial property. followed by calcium hydroxide sealers. And the last option, if you have budget issues, then you can go for zinc oxide sealers. So bioceramic sealers have shown to provide very least micro leakage and very good antimicrobial effect. So that is the reason that we would be going more ahead with bioceramic sealers in case of necrotic tissues. But yeah, in case of vital tissues, you can still use zinc oxide sealers if you have to, seal it same day. Now, clinical consideration depending upon special situations. Now, the first thing is same day if you have to place the post. If you have to place the post on the same day, you can go for calcium hydroxide sealers or zinc oxide sealers rather than going for bioceramic sealers, because bioceramic sealers have very slow setting time. So you have to avoid bioceramics and go with calcium hydroxide or zinc oxide. Next is when you have a large periapical infection, the first choice and the first and foremost has to be a bioactive mechanism where we are enhancing the production of more amount of hydroxyl ions and the calcium ions. So in these cases, we have to go for calcium hydroxide based sealers, which are more significant as compared to that of the bioceramic sealers. Next is in your cases of open apex, that is apexification case. So we need to have tissue induction property. That is, we are causing apexogenesis and apexification. So of course, we are in this case, when we are doing the sealers, we are doing apexification. So in case of apexification, we want an MTA apical plug as well as the sealer. In this case, also we are going to go for bioceramic sealers because they have the property of having active properties of releasing calcium and hydroxide. Next is when we anticipate that we might have to go for a retreatment case. In those cases, please do refer for zinc oxide sealers. Do not go for bioceramic sealers because bioceramic sealers are very, very difficult to remove. The next would be the adhesive restoration plan. So if you have adhesive restoration that we have to plan, so avoid zinc oxide sealers. You can go with epoxy resin sealers, that is AH plus sealers, specifically in your anterior cases, and bioceramic sealers. The last would be the single cone obturation technique, though we should always go for lateral cones so that we have a proper seal. You should use your spreaders to provide, even though if you're providing two accessory cones, make sure that in cases of wide canals, you should go for accessory cones in case of anteriors as well as the distal and the palatal canals. So bioceramic sealers could be the preference choice. So evidence-based approach shows that no single sealer is ideal for all situations. You have to select your sealer depending upon what was the pulpal status, what is the restoration that you're going to plan, and what is the anticipation to that of a retreatment case. Now, how do you anticipate that you're going for a retreatment case? So it's very simple. When you see that there is a periapical infection, there is a trauma case, or it's a long-standing periapical infection, there might be chances of going for a retrograde filling or going for a retreatment filling in future, right? Where you are supposed to have a follow-up of 3 months, 6 months, and 1 year. In those cases, always opt for sealers which are very easy to remove so that you can do a good amount of irrigation and helps more in retreatment cases. Now, once you have understood how you're supposed to place your sealers in which clinical condition, we also would like to focus on the different techniques that is required for placing of your sealers. So the first would be the master cone technique. Like, it's very easy. We place the master cone with a very thin layer of sealer and we insert it up to the working length in a pumping motion. So this is the very common technique that we use. Now, what mistakes that we generally do in our clinical practice is that we do not mark on a gutta percha cone. And that's where if you used a very thick sealer, it will cover most of the apical region and your gutta percha cone actually will pop out. Okay. And that's where you end up having short obturations, right? Make sure that you are coating only the tip of the sealer of your gutta percha cone. Do not fill bulk of your sealer onto the gutta percha cone. That will then ooze out more of your and cause a more pumping effect and a negative pressure on your gutta percha cone. And make sure you have done a proper marking on your gutta percha cone so that it fits exactly up to the working length. Coming to lateral spirals, of course, it's a very good technique of placing first your sealer inside so that it coats adequately to all the walls of your radicular dentine. And it should always be introduced 2 mm short of the working length because it has the capability of rotating inside the canal. And it will have the ability to extrude some kind of sealer out of the canal, which we do not want. So make sure that it is always marked with your stopper, the lateral spirals, and placed inside the canal. And it has to move in counter clockwise rotation only with uniform distribution. You could also use files and reamers for application of your sealers. Make sure you're always using a counterclockwise rotation against the walls. And it is very important to use it specifically in cases of narrow canals when you know that the canals are very narrow, or rather it's calcified. So in those cases, you can use your files, specifically your 10 and 15 number files, which can easily be introduced inside the canal. The next would be the syringe techniques. Most cases of bioceramic sealers are introduced where we use the syringe technique where we are injecting directly inside the canal, and the navi tips or the needle tips are being placed 3 to 4 mm from that of the apex and without any kind of injecting. And then when you're pulling your gun out, you can actually see how the sealer is actually flowing inside the canal. And the best part of using these pre-mixed syringes is that you can directly introduce it into the canal. And it is always best to use these because it fills all kinds of lateral canals and the fins and the spaces that is present. Now, the critical point here is please use very uniform and thin layer of sealer that you are using. Make sure that when you're mixing, if you do not have a pre-mixed, if you're mixing the base and the powder or the catalyst and the powder liquid, make sure that it has a uniform thickness. Avoid any kind of extrusion. We do not want any kind of extrusion happening beyond the periapical surface. Ensure that you have covered all the walls and you have coated. Make sure you take enough time while you're doing your obturation. And when it comes to bioceramic, make sure that your canal is moist. We need the entrapment of the moisture content, and avoid any kind of air entrapment when it comes to uh, while you're placing, because even air entrapment has the phenomena of causing some kind of air bubbles, the vapor lock phenomena. So vapor lock phenomena is not only with irrigation, but it is also with the sealers. Coming to the different obturating techniques, of course, we have the lateral condensation, we have the warm vertical condensation, we have the single cone technique, and we have the thermoplasticide injection technique. So the single technique with bioceramic sealers have proven to have a success rate of almost 94% as compared to warm vertical compaction with that of the epoxy resins having 92.3%. Now, how do we remove the sealers in cases of retreatment? So the first and foremost is which all the cases we might be needed to remove the sealers. Likewise, I told where you could have a different outlook to that of your case where you feel that you might be going ahead with a retreatment, or rather you have a case where you're going to start a retreatment. It's very important to understand how you're going to remove the sealer. So why complete removal of the sealer is very, very important, because once you have removed and once you have whatever sealer was present, you will be able to access the radicular dentine better. You will be providing a proper irrigant and a medicament for it to heal faster. So the residual filling material always has the capability of harboring bacteria. So these sealers actually penetrate into the dentinal tubules, and they also can harbor any kind of smear layer which might be present, or rather any kind of bacteria could be also growing inside. So we need to remove first the sealer completely in cases of retreatment. There are a lot of patients and there are a lot of students also keep asking that I have done a proper irrigation and still I see that there are some kinds of radio opacity still present in the radiograph and what I showed you. So those radio opacities, if which do not look very familiar to that of the root canal, are the sealers which are still entrapped inside the small dentinal tubules, and it has to be removed physically. So the goal here will be maximum debridement of that of the root canal system. So we have different types. We have easy, moderate, difficult, and the most difficult. So the easy is zinc oxide and calcium-based sealers to remove. We have moderate sealers like the silicon-based sealers. We have very difficult sealers like the AH plus sealers, and we have the most difficult sealers, that those are the bioceramic sealers. So what are the different solvents also that we could use and which are effective? So the first is, of course, the chloroform and the xylenes are the different solvents which helps us dissolve the zinc oxide sealers. We also have the endosolve R, which is very commonly used. Uh, we use it and it helps in removing the resin-based sealers. And we have the MT and the bioceramic sealers are very difficult and they do not have any kind of effect with the solvent that is going to be present. So these are the different retreatment techniques, which are heat and the hand files, the rotary techniques and the ultrasonic techniques. So I will not be going much detail in treatment techniques here though. And here are the sealer ability and the comparative summary of all the sealers. Anybody who would be interested can take a screenshot of this, even though I would be sharing a few important slides today with all of you who are present. So what makes epoxy sealers the benchmark? Why everybody is running behind AH plus sealers? That's because it is considered to be the gold standard, having excellent dimensional stability and very low solubility and superior ability for minimal shrinkage and very long-term success. Whereas, yeah, difficult sometimes in retreatment and it is very technique sensitive. So I would like to conclude here is doing a very good irrigation and a biomechanical preparation, finding all the canals is very important, but what you are exactly leaving inside the canal is the sealers and your obturating material. So when you're using a proper technique of placing your sealer inside the canal, when you're actually clinically signifying how you're going to differ, which case in which you're going to use which sealer is very, very important to have a scientific knowledge and a basics of providing which sealer you're going to use in all conditions of pulpitis cases. So this is a summary and a takeaway. You can just take a screenshot for all the evidence-based and clinical benchmarks of different kinds of sealers to be used in necrotic cases, retreatment cases, and providing an overall seal. Now, these are the sealers which are by D-Care. There's a strontium-based sealers which have just come in the market a year back. And I have used a few cases with SP C-root sealers. These are having very important biocompatibility and antibacterial properties. So you can go ahead with SP, that is C-root SP sealers, as well as MRC has also come up with root fikes and zinc oxide sealers. These sealers have the ability, like you can see it in the first photo, that they have the pre-mixed syringes which can easily go into the root canal and it can provide a better biomechanical seal. So you can use these pre-mixed syringes, that is root 5X by Mark. Now, a very controversial question here. Should we extrude sealers out of the apical foramen? My answer would be a no. Everything that you have to do has to happen inside the canal. Please do not make big puffs. Please do not feel that you have made a big puff and that is going to help in healing the periapical tissue. No. Extruding anything out of the periapical tissue is going to act as a foreign agent for the other bacteria and your body to react to that immunity. So hence, extruding any kind of material out of the apical foramen is not considered to be clinically significant. There are a lot of papers and research work going on, and it has been proven that everything has to be inside the canal. Even though if you want to still debate on this, a few millimeter cube of periapical puff for a seal is still considered adequate enough to provide the seal. Otherwise, your gutta cone should have a tuck back seal to give it the exact dimension and the monoblock that we want to achieve while doing an obturation. So make sure that sealers do help in providing sealing to the accessory anatomy of the root canal, but do not extrude any kind of material outside the root canal, whether you're using an or doing an over instrumentation or pushing the debris or pushing your calcium hydroxide medicaments or any kind of sealers is not considered to be advisable. Now, which root canal fillings are most likely to extrude? That depends upon the viscosity, the flowability, the setting time, the hydrophilicity, as well as the thermal expansion of that of the sealers and the root canal filling material that you're going to use. So you can take a photograph of this summary table, which helps in telling us routine procedures of root canal require which kind of root canal sealers is recommended, the brand names. Sorry, as well as we have the rationale and the PubMed references here given, where and how we are supposed to place the single cone techniques, how we're supposed to use it in a moist canal, tooth with having open apex or large periapical um, uh, lesions, as well as in cases of retreatment, also in pediatric cases and primary teeth, and also when you're going ahead with any perforation repair or a root end filling material. So thank you so much for giving this wonderful opportunity, specifically to Medno also for being a part of today's program. It was a very lively session, and I'm open to questions. And if you have any queries, you can always get back to me on my Instagram ID, that is Smile with Arya. And I would also like to declare here that we have three important gifts. We'll be sending it to the participants here. And it all depends upon how good the feedback I receive about today's webinar on my Instagram ID. You can send me personal feedback. Please be very honest regarding the feedback that you will be sending me. And out of three feedbacks, I would be choosing three of them. And we would be sending something to you as a Christmas gift from DK Dental that you could use in your daily root canal procedure treatments. Make sure that your summary or rather your feedback is not something very fancy. I'm not looking to anybody praising, but yes, I would love to listen to any kind of suggestions or any kind of additions that you would like me to go ahead with. Because this is the last webinar of 2025, and this is considered to be my 21st webinar of my whole journey of my doing education of my foundations or academics or workshops and online sessions. So on this 21st webinar, we are giving out a few gifts to three of the participants with the best feedback that I receive on my Instagram, whether you can post it as a story, or rather you can send me a personal message. Be very frank, be very familiar, and do come up with whatever questions you have. So I hope that this session has helped everybody out there. And if you have any queries, I'm most welcome. Thank you so much.
Thank you, ma'am. Thank you for such an insightful and engaging session. Your expertise and practical insights made this webinar truly valuable for all of us. A heartfelt thank you for all our participants for taking the time to join us today. We hope you found the session informative and enriching. On behalf of Medworld Expo, we truly appreciate your presence and support. We look forward to welcoming you to many more knowledge sharing sessions in the future. And thank you for this wonderful session, ma'am, once again. Would you like to have any closing note, ma'am?
Yeah, so yeah, I'm good with this, and if anybody who is like everybody who is comfortable can switch on their video, and we could just have an interactive session. In case if somebody wants to ask something, you're most welcome. And otherwise, you can all be coming back to my Instagram ID, and we can end the session.
Yeah. Thank you, ma'am. Thank you for this wonderful session again.
Thank you so much.
Welcome.